Hi. So today we shall be discussing a different type of stress urinary incontinence called restricted mobility or hypomobile stress urinary incontinence. So as you can see, stress incontinence is essentially leakage of urine that happens with strenuous activities such as coughing, sneezing, or straining. Sometimes some women will even complain of urine leakage with minimal activities such as just standing up or sitting up from a lying down position or simply walking. So let us again do a little recap about anatomy of the pelvic viscera. So this is a woman from the side looking at, this is the head end, this is the foot end, this is the front, and this is the back. So right in front is the pubic bone. The pubic hair would be here. Behind the pubic bone is the bladder, which is the storage organ for the urine. Below the bladder is the tube called the urethra, which in a woman is just a 4 centimeter short tube to the outside. Behind the bladder and the urethra are the vagina and on top the uterus. Now this is the uterus, and that is removed when a woman has had a hysterectomy. And behind that is the rectum and then the buttocks. So this is a typical manner in which the pelvic viscera are present in a female pelvis. The bladder, which is this, and the urethra is this tube down here, are very important for a synchronized mechanism of urination and storage. So as the bladder is filling up here, so you can see as it's filling, the urethra is closed. The urethra only opens up when the bladder is contracting and emptying. All this is governed by the nervous system. Hypomobility of the urethra is a condition where this is the bladder again, this is the urethra. So typically when the patient strains, there is a tendency for the urethra to fall back. So for example, if someone pushes me from the front, there's a tendency for me to go back. However, if I'm already back against the wall or against the back of this chair and someone tries to push me, I cannot go anywhere back and I stay where I am. So when you have a fixed urethra, it does not budge. In a hypermobile urethra, it tends to fall backwards. The reason why in a hypomobile, that means restricted movement of the urethra, why do you get urinary leakage is mainly to do with the urethral muscle sphincter. So see, this is how a normal urethral sphincter should look, tightly closed, and I'll show you another picture of this. But if it is weak and opened up, like in this case, then there is a chance of urine leakage, despite the fact that the urethra is well supported. It is not falling back, but it is weak from the inside. So let's look at a cross section. So looking at a horizontal cut section of the urethra. So this is that lumen that I showed you. So remember this lumen right here and this tiny lumen right here. So lumen is the cavity of the urethra from where the urine comes out. So that is the lumen. Around that are the blood vessels, the lining of the urethra, and all these folds that keep the urethral lumen small. Around that is what's called a smooth muscle coat and then a skeletal muscle coat. The difference is that the smooth muscle coat is controlled by the nervous system, whereas the skeletal muscle coat is controlled by us. So when you flex the biceps, that's the skeletal muscle. Similarly, when you are trying to contract that urethra, you do not want to lose urine and you're squeezing around the urethra, you're contracting this outside muscle called the rhabdosphincter. So that is a muscle that envelopes the urethra. So now again, give you an orientation. This is the bladder, this is the urethra, and this muscle that envelopes the urethra called the rhabdosphincter stays tightly contracted and closed when a patient squeezes. Also, there's a muscle coat on the inside which works together. So the urethra is supported by the smooth muscle coat and also called the other muscle called the skeletal muscle or the rhabdosphincter. So why do we get stress incontinence when the urethra is fixed? Now this happens typically in a postmenopausal situation. So let's go back to that slide. So here, because the blood vessels become quite small after menopause, this lumen cavity increases. And if this cavity increases, there is a tendency for leakage to happen. Also, the muscle coats become thinner after menopause. So very often seen in postmenopausal ladies, but could also be seen in younger women who have not had children. In other words, their pelvic support mechanisms of the muscles are very good, but the urethral muscle is weak. This is also seen after a bladder suspension procedure where the tissues around the urethra has been elevated, but the urethral muscle itself is weak. So what are the typical complaints? Obviously, stress incontinence, meaning leakage with laughing, coughing, sneezing, lifting, any exertional activity can cause the leakage. But sometimes it may not be associated with what is thought as exertion. For example, as I initially mentioned, the patient just sitting up from a lying down position or standing from a sitting position or just walking could notice leakage. Then as the urine is coming out, she may feel, oh my God, the urine is coming out. So now she gets this got to go feeling. And she may say that I have urgency and I am leaking on the way to the bathroom. Now, why is this important? Because this could be misconstrued or misinterpreted. That means falsely interpreted as a bladder problem, where the bladder is contracting and that is why the urine is coming out as she is making her way to the bathroom. So, if this is misinterpreted as overactive bladder, she would then be managed with medications for the bladder, and that would be totally wrong. So you see, the symptoms are important, but sometimes they could also be deceiving. Patient may also say that she has this constant dribbling of urine. So when she's standing up, she feels that, anytime she's walking, there's a little bit coming out. Why? Because if the urethra is weak and the bladder is filling up with urine, guess what's going to happen? It's going to keep coming out because the urethra does not have the strength to tighten up. So that's why we have to do a proper history examination, and I'll talk to you about each of these tests. So we will have you fill up some questionnaires, which will help us differentiate a little bit between the urgency and the stress incontinence. But just like what I mentioned, even the history can be deceiving. Then on examination, this is one of the giveaways. A patient is lying down, her bladder is empty, and we are examining her and asking her to strain. And guess what? She has urinary leakage when she strains. So then you know that this is stress incontinence. Then we look at the urethral anatomy and see that it is fixed and it is not moving. And that tells us that this is a hypomobile urethra and not a moving urethra. If the patient doesn't leak lying down, then we have her stand up. And if she leaks standing up with an empty bladder, that's called a standing cough test. Once that is done, we do what is called voiding diaries or urinary diary log. And that is where a patient slides a hat under the toilet seat at home, and then she measures how much she goes. So for example, as you can see, this is 200, this is 400. So she has urinated about 300 cc's. She doesn't have to keep it. She just has to note it and throw it away and then restart that. And that gives you the accounting for the 24-hour diary. And we also do a 3-day diary to see how often is she going to the bathroom and when does she have any leakage based upon the index up here. Once that is done, we do a test called urodynamics, and this is a pressure recording. And this is very important because here we can record the pressures of this thing called P-ura, or the urethral pressures. Now let me explain what that is. So this is the bladder. This is the urethra. So as the pressure catheter is coming slowly outside, the middle part of the urethra is very strong. So as you can see, the catheter is coming out, the pressure, this is the bladder pressure, it's coming down, and then it goes up until it peaks, and then it comes down, and now it is outside right here. It's out in the air. So this is the bladder pressure, but you can see that in this case, the pressure is as good as 100, and the bladder pressure was 20. So 100 minus 20 is 80. So it is 80 centimeters better than the bladder pressure. And because the urethral pressure is high, it maintains the urine in the bladder and maintains continence. But if the urethral pressure becomes weak, like what I showed you, and the pressure is very minimal and very low, less than 20, then you'll have urine leakage. And that is called intrinsic muscle of the urethra sphincter deficiency. So intrinsic sphincter deficiency. So now that we know what hypomobile urethra is and hypomobile stress incontinence is, why does it happen, what are the symptoms, how to come up with a diagnosis, let us talk about how to manage it. So the key thing obviously with anything is diet and exercise. Remember, diet and exercise. Diet in this case is drinking appropriately, typically about 60 ounces in a day. If one is drinking 100 ounces and going less frequently, she's very likely to have incontinence. So the first thing is to restrict the amount of fluids to what is appropriate, which is about 60 ounces. Then going to the bathroom every 2 to 3 hours when one is awake so that she can empty her bladder and it doesn't become too full. Because if the bladder gets too full and someone sneezes or coughs, then almost everybody could have a little bit of leakage. So make sure that you go periodically to the bathroom. Then we'll talk about these three conditions. So what's pelvic floor therapy? Pelvic floor therapy is where the pelvic muscles, so these are the muscles that control and go around the urethra, the vagina, and the rectum. So by squeezing and tightening those muscles with electrically stimulating them, which is done in the office, we can make the muscles stronger. And this is by using a very tiny probe that's placed in the vagina. And with that, we stimulate the muscles to become stronger. So what you achieve with that is recruiting or hiring, so as to speak, more muscles to become active, engaged, and also contracting together. Not some muscles contract in one direction, others contract in another direction, but now they're all contracting in one single direction and all together, and that gives rise to the strength of the muscles around the urethra and helps with continence. This is done in the office. There is no pain, no discomfort, no anesthesia. It takes literally about a few minutes to get it done, and it's once a week. It's done for about 4 to 6 weeks, and the patient is given some homework to do at home. So not just you come in the office and that's it. No, you got to go home, and just for a period of only about 2 to 3 minutes. Remember, 2 to 3 minutes per day is all we are asking you to exercise at home for your pelvic muscles. That's all. I'm sure all of us can spare that. There is no discomfort, there's no pain. The success with this is not very high, but at least somewhat improved compared to not doing it. The other thing that we do is something called transurethral bulking procedure. And there are different agents that have been used. What we use is an agent called Macroplastique, which is a silicone polymer, and the others are carbon-coated beads called Durasphere and coaptite. So this is done at cystoscopy. So here the patient's lying down here, head is up here. She's watching, completely awake under local anesthesia. I'm watching on the TV screen, and we are watching the inside of the bladder and then coming out into the urethra. So this is done right in the office, completely under local anesthesia. Macroplastique is the agent that I use, and that has been around for many, many years. 1991 in Europe and 2006 in the United States. It's the most used agent in Europe today, and it is non-allergenic. It is a silicone elastomer implant, which is suspended in something called a PVP matrix. So that's just a carrier, but the main agent is a silicone elastomer implant. After implanting, the PVP carrier is discharged or excreted, and it is replaced by the patient's own tissue called the fibroblasts, which is the healing tissue. The silicone implants favor fibroblast activity, and that forms a stable matrix. So this is how the macroplastic comes in. It comes in like 2.5 to 3 ml syringe. And what we then do is with a tiny needle, if this is the bladder right here, this is the urethra, this is the junction of the bladder and the urethra, we put the needle right under the lining of the urethra and then create these two little balls. And this is the macroplastic ball. See what is happening? The urethra, which is wide, is now narrowed down. The goal is to narrow down the urethra. So this is the urethra, which is open. And because it is open, patient is leaking urine. We put this agent on one side. As you can see, as this needle is going in, you can see the needle going in. It has already formed a ball on the other side, and now it is forming a nice ball on this side. Guess what happens? This open area of the urethra is now completely closed off. You've got one ball on one side, one ball on the other side, and that results in two balls and narrowing of the urethra. The principle is of physics, very simple principle. UL is the urethral lumen. So this whole black thing was a urethral lumen. It was a big one before that, but now that we have created those balls, the urethral lumen has narrowed down. Once the lumen narrows down, the urethral pressure being inversely proportional to the area, that means as the area of the urethra decreases, the pressure goes up, and that results in, again, continence or the patient being dry. So the macroplastic is put on one side, then it is put on the other side, and that's how it works. So it could either be coaptite, macroplastic, or DuraSphere. These are the three agents which are available in the United States. So when the patient has a full bladder, she's asked to cough, and guess what? Nothing happens. There's no leakage. That means we know that what we've done is now successful. This is the tissue response. So as I mentioned, the matrix, the outside, the agent that is the vehicle for the macroplastic disappears, and it is replaced by the fibroblast or the normal patient's healing tissue. So it creates a nice little encapsulation. So now these balls remain there and are not discharged or absorbed, or they do not migrate. So how successful is this macroplastic procedure? 75% of patients notice improvement, and 43% are cured at short term, which is within 6 months, which is very good. And almost 3/4 are improved, and almost 40% are completely cured. At about 6 to 18 months, similar numbers are improved, and about similar numbers, about 40% are cured. And over 18 months, 65% improved, and about 40% are cured at long term. So you could almost say that about 70 to 75% of women will notice improvement, that they're happy that things are going well. They may still have some leakage, but overall happy. And almost 40% will say, hey, I don't even need to wear a pad. It's all done. I'm very happy. And what they found is 85% of women who are successful at 6 months continue to be successful at 2 years. So that's a good thing. That means if you're dry now, the likelihood of you being dry later on is also very high. But then again, if you have recurrence of leakage, no worries. We can always do the re-injection. It's an office procedure. You can come back and we can redo it. If I did it more on the left side, now I'll do it more on the right side. Typically, about 1/3 of patients need a re-injection. So what are the complications? What bad can happen with this? This is a very well tolerated polymer. It has got very few side effects. Initially, just because I did the procedure, there is some discomfort during the procedure, slight discomfort, urination after that, but that's maybe a few hours and it's gone. 7% chance of temporary retention. Remember that. Temporary retention means difficulty emptying. Temporary, that means it's very short-lived, maybe a few hours, maybe a few days, and then it's back to normal. 10 to 20% chance of urinary tract infection. In our series, it's much less because we give you an antibiotic to take so you do not get a bladder infection. The only time this becomes a concern is if you are catheterizing yourself, but then again, we prevent it with the antibiotic. There are no known serious adverse effects of the macroplastic. No reports of this traveling all over the body called migration or any immune reaction to the macroplastic. In the past, we used to use something from cows called collagen, and for that we had to skin test. For this, we don't need to do that. So all in all, it is done completely under local anesthesia. It literally takes 5 minutes to perform this procedure. So the moment I actually start the procedure, it's done in about 5 minutes. That's how quick this is. There is some discomfort because when I'm putting this, even despite the local anesthetic, when I'm putting this agent, because it's a thick paste, as I'm putting it in and I'm putting in a tight space, it's going in that space, and because it's a thick agent going in a tight space, it causes that compression effect, and that is what causes the discomfort. So patients are taught how to self-catheterize in case you have to do it. As I mentioned, less than 10% chance. So only 1 in 10 women may have to do it. Most women can empty the bladder well. After the procedure, once it's done, we'll make sure that you're emptying your bladder well, or if you're catheterizing yourself, then you know how to take care of it when you go home in case you are not able to empty. Again, over 90% of patients, 90% of patients who have this done can empty their bladder right away. So don't worry. Even if you are in that 7 to 10% category, remember, it's a short-lived affair. We give you an antibiotic, something like an antispasmodic to help you. This is, we teach you how to catheterize, so in case you have to do it, you have to keep your own control so you know how to do this on your own. Contraindications, when can you not do this? If the patient has an active bladder or urethral infection, if the urethral lining is extremely weak, for example, there's a fistula, then it won't work, or if the patient is not emptying her bladder. Medically, if the patient is on a blood thinner, then we cannot do it. But that's again a temporary thing, being on a blood thinner, because if you can get off the blood thinner, if your doctor approves it, then we can still do it. But if you're on a heavy duty blood thinner, then we cannot do it because of the risk of bleeding. After the procedure, what do we do? You should empty your bladder every 2 hours when you're awake, and may follow up in the office. If you have any doubts, am I emptying my bladder well or not, what's going on, then you may want to come in the office. We'll do a quick bladder scan and make sure that you're emptying your bladder well. We'll follow up with you if all goes well in about a month to make sure you're doing well. And you should inform us if anything is happening. You're having difficulty emptying, you feel like there's a bladder infection, you have discomfort emptying or heavy pain, call us. Next steps is, if you're on a blood thinner, we'll have to get off that. We'll schedule the procedure and you'll have to come in to learn how to do the self-catheterization procedure. Now, patients usually ask me, doctor, why can't I have the sling procedure? I have stress incontinence. I know the sling is meant for stress incontinence. Why can I not have it? Well, because remember, you do not have hypermobility. Your urethra is fixed. It's not falling down. If it was falling down, then a backstop helps. So you need this urethra to fall backwards, and then is when the sling is effective, because when the sling is placed under the urethra, which is falling down, so if this is the urethra and it's falling backwards, I would put a strap under it, so now it cannot go anywhere and it blocks it. But for that, you have to have the urethra fall back. Now, what if it was not falling back and it was fixed, and my sling is below this, and it's not pressing anymore or not falling against it? It won't be effective. That is why in most cases of fixed urethra, a sling does not do well, because it is a fixed tube. Now, sometimes we may do, if all else fails, do something called obstructive sling, where we are actually making this sling very tight under the urethra. Usually I try not to do this because it can cause problems with emptying ability, then patient has retention problems, so we try to avoid this as much as possible. All in all, stress incontinence is a common problem. It affects women of all ages. Women who have a fixed urethra can also be helped. Granted, in our hands, the results with the sling have over 95% success and long-term success. But with this too, we have options. With pelvic floor therapy, timed voiding, fluid management, and the bulking agents, this does excellent. You have anywhere from 70 to 75% chance that your symptoms will be significantly improved, and about 40 to 45% chance that your symptoms will be completely cured. Remember, it's an office-based procedure, so even if I have to redo it in a few months, it can be done easily in the office. Also, this is not an experimental thing. This has been around, as I mentioned, for over a decade in the United States, and it is approved by all insurance companies.